Good evening and good morning to all who have joined this one of the interesting webinar organized by the Journal of Hand and Microsurgery on the interesting topic scapholunate injuries. Thanks to Shrikant, of course, who has been the person who has been very instrumental in organizing this webinar. Thanks to Dr. Ruby, Dr. Andrea, and Dr. Abhijeet for the panelists here. Today is a special and auspicious day for us. It's called as the International Labor Day, and even Maharashtra state, who Abhijeet is coming from, has a special auspicious day. With few words of wisdom of how hard work plays a role in the life of any surgeon. I used to quote the famous Tirukkural from our own language. It says that Devatal ahadu, muerchi dan mevartha kolitarum, meaning to say that even God thinks it is impossible, all your hard work and your commitment and your diligence will definitely make it possible. With these few introductory words, I would like to start this meeting with Dr. Shrikant taking over and introducing his speakers, and we will go with the webinar. Thank you, Dr. Shrikant. Please go ahead.
Thank you. So, thank you, Dr. Jerome. It's my honor and pleasure to introduce our speakers today. So let's look at the presenters this morning. I'm honored to present Dr. Andrea Chan. She is one of the most wonderful surgeons and fellow that I worked with at the Hand and Upper Limb Center. So she graduated from University of Toronto Faculty of Medicine back in 2012. Following her medical school, she completed her residency in orthopedic surgery at the University of Toronto in 2017. Dr. Chen then completed one-year fellowship in adult hand and upper extremity trauma in London, Ontario at Roth McFarlane Hand and Upper Limb Center. And we used to call that as HELC. HELC means a great center, that is of Center of Excellence in Canada. Where she worked with shoulder, elbow, wrist, and hand trauma. And along the same line, she did work on arthroplasties, arthroscopy, as well as performing peripheral nerve injury as well as surgeries. Her research in London was focused mainly on biomechanical analysis of the wrist, reconstruction techniques, and looking at carpal instability cadaverically and doing some analytical work. So she then pursued a second 6-month fellowship in pediatrics, pediatric upper extremity at Cincinnati Children's Hospital, and Dr. Chen then joined hand program at the Toronto Western Hospital University Network back in 2019. Our second presenter is Dr. Ruby Grewal. She is the most published surgeon from Hand and Upper Limb Center. She received an MD degree from University of British Columbia with specializing in orthopedics. She completed 2 fellowships, one at Roth McFarlane Hand and Upper Limb Center in London, Ontario, and then the second being at Royal North Shore Hospital in Sydney, Australia. Along as she was doing her fellowship program, she completed a master's degree in epidemiology and biostatistics in 2006. She is an active member of Department of Surgery at University of Western Ontario. She is also a co-director of Clinical Research Lab within the Roth McFarlane Hand and Upper Limb Center. So Dr. Grewal has been awarded, or she received many awards, and one being from the Schulich School of Medicine. And besides that, she had numerous excellence awards in Orthopedic Association, one being the International Traveling Fellow. She has published over 100 scientific articles, and she has written about 30 book chapters. She's also a deputy editor of Journal of American Academy of Orthopedics. She does global research and reviews journal, and spent over 12 years as an associate editor of Journal of Hand Surgery, and that being American Journal of Hand Surgery. So Dr. Grewal, her elective practice involves all aspects of hand, wrist, and microsurgery. Her trauma practices focuses on injuries involving the hand, wrist, shoulder, and elbow. So one of the excellent surgeons from Hand and Upper Limb Center, or Roth McFarlane Hand and Upper Limb Center, that I have known her for many years. Our last speaker is Dr. Abhijeet Wahegaonkar. He's one of the renowned surgeons from India. He's an orthopedic surgeon. He's also an adjunct professor of hand surgery. He's distinguished clinical tutor of orthopedic surgery. He's the director of Upper Limb Hand and Microsurgery Fellowship Program. He acts as a consultant and head Department of Upper Extremity Hand and Microvascular Reconstructive Surgery at Sancheti Institute of Orthopedics and Rehabilitation, as well as at Jahangir Hospital in Pune. He has 35 peer-reviewed publications. He has written 18 textbook chapters. He has presented more than 300 papers and 60 invited talks in international and national conferences. He is a visiting professor to Shahid Beheshti University in Tehran. He also is a visiting professor to Strasbourg, France, and IRCAD in Taiwan. He is a founding president of Wrist Society of India. He is a member of American Society for the Surgery of the Hand, French Society of Hand Surgery, and European Wrist Arthroscopic Society. He has an international investigation workshop he conducts often. He's a founding executive council member of Asia Pacific Wrist Association and chairman of the committee or international committee. He's an executive committee member of Maharashtra Orthopedic Association. He's also a chairman for Fellowship Committee for Maharashtra Orthopedic Association. It's my great honor and pleasure to introduce all the three speakers. They are very renowned in their field of work that they do. And I'll ask Dr. Andrea Chan to start off with her presentation on anatomy and biomechanics of the scapholunate joint. Thank you.
Dr. Andrea.
Great. Well, thank you so much, Terrence, for hosting this webinar. It's wonderful. And thanks, Shrikant, for that introduction. Can everyone hear me and see my presentation? Great. So I'm going to start off this webinar to speak a little bit about the anatomy and biomechanics of the scapholunate ligament and the joint itself, one of the topics near and dear to my heart. And so I have no disclosures here. So this is a typical patient that I would see in my clinic. This is a 40-year-old gentleman. He's 1 year following a fallen outstretched hand, and he presents with dorsal central wrist pain and a positive Watson's click test or the scaphoid shift test clinically. And so we can appreciate these static changes on X-ray with the scaphoid increased flexion with the signet ring sign, the lunate extension, and on this pencil grip view, we note a more dynamic change with an accentuation of the scapholunate diastasis, proximal migration of the capitate, as well as pronation of the scaphoid and the distal row. And so when presented with this type of patient, I ask myself, can the altered wrist anatomy and biomechanics be adequately restored with any of the particular reconstruction techniques that we have today of the scapholunate ligament complex? And so that brings us to the concept of stability. And scapholunate stability itself is conferred by multiple things, but primarily by its ligamentous structures, by the geometry of the carpal bones themselves, and also by sensory motor control. And this is in comparison to the concept of carpal instability, which requires three tenets. It requires the patient to be symptomatic, unable to bear loads, and an associated abnormal kinematics. So when we first focus on the ligamentous constraints of the scapholunate ligament, we have the primary stabilizer, which I'll focus on in the next slide, but this is a scapholunate interosseous ligament, and it comprises three components, the dorsal, volar, and membranous. and also secondary ligamentous stabilizers. This is primarily on the volar side, the scaphotrapezio-trapezoid ligament, the radioscaphocapitate ligament, the long radial lunate ligament, and also some dorsal extrinsic capsular ligaments, primarily the dorsal intercarpal ligament, the DRC, as well as the more recently described dorsal capsular scapholunate septum. So we focus on the primary stabilizer of the scapholunate joint, which is the scapholunate interosseous ligament. Berger eloquently demonstrated in the 90s through his cadaveric study that the dorsal component is the strongest, and the breaking point is about 200 newtons. And this component primarily resists distraction, torsional, and translational forces. Whereas in comparison to the volar component, which is about half the strength, this primarily resists rotational forces about the joint. And then the third component, the membranous or the proximal portion, really confers very little strength, and in fact might be more contributory to the sensory motor or neuromotor control. When we look more into the biomechanical properties of the scapholunate ligament itself, there's a number of studies, but this one in particular by Lee and colleagues. This was done actually on normal patients with static wrist positions in MRI, and they were looking at the strain that was going through the scapholunate ligament and its components. And what they noted that in the neutral position, the purple, the strain was actually very low through the ligament itself, but as the wrist got more and more extended, the scapholunate ligament, particularly the volar and membranous components, experienced very high strain. And this is reiterated in cadaveric in vitro studies. So this one part by Dimitris and colleagues demonstrated that with cyclical dart throw motion and flexion extension motion, going through flexion and extension here, the scapholunate ligament sees maximum tensile forces again in extension. So when we're starting to understand the forces that are seen through this very important ligament. And then we focus again on secondary stabilizers. We must remember that these secondary stabilizers, they do not replace the scapholunate ligament if it's fully disrupted. And they, the multiple components, the STT ligament, this primarily resists excessive scaphoid flexion and pronation. The radioscaphocapitate ligament, it resists distal row pronation, as well as ulnar translocation of the whole carpus. And the long radial lunate ligament. So this again resists ulnar translocation of the carpus, scaphoid pronation, but is also quite important in resisting lunate extension. And this interesting concept of the screw clamp mechanism, when looking at the dorsal extrinsic ligaments, McConnell back in the 1940s described them working together like a screw clamp mechanism, wherein with wrist extension, they both tighten together, tighten the proximal row such that when the capitate proxima migrates, it tightens around the capitate, the screw clamp mechanism. And then I had mentioned before this DCSS. So this particular structure is a reflection of the DIC, so the extrinsic dorsal wrist ligaments, which actually attach to the lips of the lunate and the scaphoid via the dorsal scapholunate ligament. And it's been described more recently by both Methuen and Van Overstraten. And they found that while sectioning this alone does not produce any static radiographic changes, it has been shown that after sectioning, it does increase the arthroscopic scapholunate instability staging. So we know, again, this capsular reflection does start to play a role in the stability of the scapholunate complex. And so moving from the anatomy itself, Now we need to look at the biomechanics in order to understand best how to reconstruct this. And as you know, Mark Garcia Elias has eloquently stated, the understanding wrist biomechanics is a long and winding road. And I must say that we're probably still in the midst of all these switchbacks. So it's very complex, and I think we're still gaining much understanding. So there's a couple concepts I just want to clarify. So when we're talking about biomechanics, kinematics looks at how the ligaments and carpal geometry contribute to normal motion, whereas kinetics examines the effect of force and torque on the wrist and its response to maintain stability. And so one of the earliest descriptions of wrist biomechanics is this column theory or column concept popularized by Navarro and modified by Telesnik. But basically, this stated that in this coronal plane, the central column was the stable column and the scaphoid is a stabilizing link. This concept has evolved with the application of very simple mechanic equivalents. In the sagittal plane, the radiolunate and the lunocapitate joints were described as link joints. And then Linscheid applied the mechanical equivalent of the slider crank mechanism to describe the motion between the proximal and distal rows, wherein the scaphoid acts as a rigid connecting rod, and actually labeled this lunate and triquetrum segment as the intercalated segment. And Landsmeer and Fisk both applied, again, another mechanical equivalent to when the carpus collapses, there's this concertina effect or the zigzag collapse, which we know and describe as the DZ deformity. Lichtman then proposed the oval ring theory, which basically identified that kinematics is more complex than just linear motion pathways in either the sagittal or coronal plane, and that reciprocal motion actually occurs between the proximal and distal rows in a ring fashion. And then lastly, more contemporary computational analysis done by Sandow actually demonstrated that there's isometric pairings between various carpal bones. And these actually kind of correspond with known intrinsic wrist ligaments. And in actual fact, it sort of mimics this central column theory. And all of these work together to resist lunate extension. And instead of describing this as a slider crank mechanism, he uses a slightly more complex mechanical equivalent of the 2-gear 4-bar linkage system to describe the motion that's occurring there to resist the lunate extension. So when we start to look at intact wrist motion, what is actually happening? So when we look at flexion extension, what we see is that the scaphoid and lunate actually rotate in the same primary direction as the wrist. So if you're flexing the wrist, the scaphoid and lunate will flex, but the relative motion of the scaphoid is greater than that of the lunate. And then when we start to apply force, well, what actually happens? So if we add axial compression through, the scaphoid flexes, the distal row starts to pronate, the lunate follows a slope of the distal radius ulnarly, and the triquetrum extends or flexes depending on the amount of force going through the wrist. And the opposite actually occurs when we apply axial traction. So the scaphoid extends, distal row supinates, and the triquetrum flexes. And then what happens in the intact wrist with contact area and pressure? Well, we know that these from studies that the area and pressure change with motion and load. And the scaphoid actually sees about 1.5 times greater contact area than the lunate with wrist motion. And in particular, when we start to hyperextend with radial deviation, we start to see that contact area shift both radial and dorsal. And when we actually apply a hyperextended position through the wrist, and compare intact scapholunate ligament versus a section scapholunate ligament, we start to see peak pressures translate in the radioscaphoid fossa to that dorsal radial rim. And so we can start to appreciate why we see those changes in early slack wrist. It's because of this change in this contact pressures. And so how is it that carpal collapse is actually prevented in the intact wrist when loaded? Well, Mark Garcia Elias described carpal stability as occurring through the self-stabilizing mechanism. And in particular, he actually described two sets of ligaments. One is a helical antipronation ligaments, I'll call them the HAPLs, and they actually confer scapholunate stability, and I'll focus on those, whereas the anti-supination ligaments confer midcarpal stability. So when we look at these HAPLs, they're made of both intrinsic and extrinsic ligaments here. And as you can see in this middle diagram, they're all obliquely oriented, and they form a helix around both the radial and middle column. So the posture of the lunate is maintained by both the flexion moment of the scaphoid, but also the opposite triquetral extension moment. And so Garcia Elias compared these two with axial compression, like wringing out a wet towel, and with axial traction, like the tightening of a Chinese finger trap. And so when we actually disrupt the scapholunate ligament, or a patient disrupts this, how do kinematics actually change? When we look at scapholunate dissociation, we actually require the scapholunate ligament itself to be disrupted, as well as disruption or attenuation of at least one of the critical secondary stabilizers. And we start to appreciate these radiographic changes. So diastasis of the scapholunate ligament over interval over 3 millimeters. Scaphoid rotatory instability represented by scapholunate angle on that lateral view over 70 degrees. Lunate extension, again on the lateral of over 15 degrees, which you can appreciate here. And also the concept of dorsal scaphoid translation, where we start to see the scaphoid proximal pull translating over the dorsal radial rim. And in vitro selective sectionings of the scapholunate ligament and various secondary stabilizers start to give us an appreciation of how all of these contribute to stability. So if we only section the scapholunate ligament, we only produce dynamic changes, and we don't start to appreciate static changes. And if we section only the secondary stabilizers alone, we actually do not appreciate any significant scapholunate kinematic changes. However, once we section the scapholunate ligament, plus various secondary stabilizers, and add cyclical motion, we start to develop static changes. And this concept of dorsal scaphoid translation, which I actually do think is quite important in restoring. Back a couple decades actually now, a study demonstrated that patients with positive scaphoid shift tests preoperatively actually performed better postoperatively if resolution of the scaphoid shift test occurred, meaning that it was likely that dorsal scaphoid translation plays a role in patients' symptoms and their relief if it's restored. A study by Perez, a cadaveric study, demonstrated that's likely a late finding though, because it did require sectioning of not just the scapholunate ligament, but multiple secondary stabilizers. And Chan and colleagues demonstrated two means of measuring this. So got concentric circles, as well as dorsal tangential line. And each of these can demonstrate dorsal scaphoid translation on radiographs. And so scapholunate dissociation really is a spectrum of disease, starting from a partial tear, which demonstrates no dynamic or static changes, going through from dynamic changes to static changes to eventually slack wrist. And it's really kind of Wolff's categories 2, 3, and 4, which pose, significant challenges to our surgical armamentarium. You know, as we continue to refine our reconstructive techniques and our understanding evolves of the biomechanics, we note that through the evolution of our reconstruction techniques, we're no longer just focusing on the coaptation of the scaphoid and lunate and just only focusing on that, on repairing that diastasis. But now we're also focusing on getting the scaphoid out of flexion and pronation, reconstructing secondary stabilizers to help with this, to help stabilize the lunate such that it's not hyperextended, but also now I'm looking at both volar and dorsal reconstructions to prevent this dorsal scaphoid translation. And ultimately, we also have to figure out how to tension everything properly such that we restore appropriate contact pressures and areas and not over tighten things. So in summary, we are still in search for a unifying kinetic model of carpal stability. And I must submit that we likely do not have an optimal surgical technique or techniques that can actually restore the anatomy, geometry, and biomechanics of the wrist in the setting of a scapholunate ligament injury at this point in time. And I don't think we're at the point yet that we have proven that there is a technique that can stand the test of time. But I'll allow my next two colleagues to talk about repair and reconstruction at this point. Thanks again for having me talk there.
Thank you, Dr. Andrea. I mean, one of the amazing talk about, very complex anatomy, kinematics, and the kinetics of about the scapholunate injury. You have beautifully articulated all those concepts, which I really enjoyed it. Most of the delegates must have enjoyed it. The scapholunate injuries, the SLIL is alone is not the one which is the stabilizer there. As you rightly pointed out, that the secondary stabilizer is also more important. They augment to the stability of the scapholunate ligament. It's obviously one of the cadaveric study which is done by Dr. Scott and the team colleagues. I really enjoyed those because we did a cadaveric study similar to Scott, and we enjoyed all those. What happens? You cut the SLIL ligament, and then the DIC of the lunate and the scaphoid portion. Finally, the STT in RSC, and you could only see the dorsal scaphoid translation at the end.
Yes.
That was really awesome to see that study. When you do it, this study is amazing, and you have beautifully narrated in your presentation. Thanks very much.
Thank you.
Stay tuned. We have a lot of questions. Next, I invite Dr. Ruby Grewal to present her talk.
Morning. Thank you very much. Or I guess I should say good evening. It's morning for us. I just wanted to say, first of all, we have all been watching the news and our hearts are with all of you in India. We know what a terrible time you guys are having with COVID, and really you are all in our thoughts and prayers. So hopefully we can talk a little bit about making the decision between saving or salvaging these scapholunate. As Andrea's pointed out, there are many different techniques, and I think any of us surgically, we can read a surgical technique and execute it. However, I think the key and the most important thing for scapholunate injuries is trying to figure out which patients to actually offer a reconstruction to and which patients are too far gone and need to be considered more of a salvage procedure. So Andrea actually came up with this title and I love it, Scapholunate, Repair or Despair. And that really, I think, is the crux of the sort of dilemma with these patients when you see them. This injury is often missed. We often will have these patients presenting on a delayed basis. When they first present, they often have vague symptoms and the x-rays don't necessarily show anything. So they're often untreated. It's very uncommon to see these, at least in my practice, on an acute basis, and we often see them once they have actually become a fixed diastasis. And we know that if we leave these unattended, they will lead to a slack arthritis. I love this quote by Lindau. Wrist problems are diagnosed even in the hands of an experienced surgeon, 3/4 of the cases by history and examination. And I think that is very true in the situation of scapholunate. The history and the physical exam are going to put everything in context, and that becomes the most important thing, despite what the MRI is showing you, and even despite what the arthroscopy is showing you. The history and physical help you put those MRI and arthroscopic findings in context. So one of the things I look for when I'm trying to decide whether or not I should try to save this ligament is whether the patient has a discrete history. Do they actually have an event, a trauma, something that actually could have caused this injury? That helps to give you an idea of how acute or chronic it may be. I also want to know what their chief complaint is. Are they having pain, just radial sided wrist pain, or is the instability actually giving them the trouble, the clunking of that scaphoid? The location of the pain, I think that any of our techniques, as Andrea has pointed out, work best when we're trying to address the pain associated with that dorsally subluxated scaphoid. And also just looking at whether their exacerbating factors fit the pattern of instability. We'll go through a few points on physical exam. First of all, the point of maximal tenderness. The Lister's tubercle is an easily palpable landmark, and immediately distal to that is the scapholunate ligament. That area there around the scapholunate ligament and the dorsal aspect of the scaphoid is where they will be painful. And if they're painful in that area, I find that a scapholunate reconstruction can be helpful. We're going to spend a little bit of time on the clunks, the scaphoid shift test, pardon me. So we all know about this Watson's maneuver, and it can be present even in normal asymptomatic patients if they just have some underlying instability. But it's when that dorsal scaphoid subluxation creates pain, and when the patient says, yes, that is the clicking I get, that's bothering me, when I reproduce that on my clinical exam, then I can be very confident that my surgery will help them. So when we have our wrist in ulnar deviation, the scaphoid is extended, and as we move into radial deviation, it flexes. And what we want to do with our shift test is actually place our thumb on the scaphoid tubercle so that when the scaphoid attempts to flex, we actually block that flexion, and instead the proximal pole subluxates dorsally. And it's pain at that dorsal point where the scaphoid is subluxating that you're looking for when you are doing this test. You want to know if that reproduces their symptoms, and always, always, always compare it with the other side. Because some patients, if they are a little bit lax, will have a clunk without necessarily pathology associated with it. Next, we move on to imaging, and we're always looking for that scapholunate gap. Everybody knows well about that. If you don't see it on the plain films, you can often get a dynamic grip view, which helps sometimes to draw out that diastasis. You want to see if it's different than the contralateral side. And greater than 3 millimeters is what I use. And again, you can see how it can be brought out more prominently if you have the patient do a clenched fist. The cortical ring sign, when the scaphoid is flexed, you will see the distal and proximal pole superimposed on each other. And we call that the cortical ring sign because you're sort of seeing this ring superimposed, the ring of the distal pole superimposed on the scaphoid. The angle, we all know the scapholunate angle. You're looking for the long axis of the scaphoid and the long axis of the lunate, and a pathologic increase is greater than 60 degrees. MRI findings, you'll obviously be aware of a scapholunate tear if it's present, but also on these images, note if there's any early degenerative changes. We know that the slack changes can come on after this type of injury, and particularly if the injury date is in question, make note of that. And again, this dorsal subluxation of the scaphoid. When I see this on the cross-sectional imaging, I actually am happy because I know that I can make these patients better. So look for that scaphoid proximal pole riding out of the fossa. The group in New York, Dr. Wolf and Scott Lee, have shown us that this dorsal scaphoid translation actually correlates strongly with pain. So their function, their surgical success is best when this dorsal subluxation is corrected. And that's actually even a more sensitive predictor than the scapholunate gap or the scapholunate angle. Arthroscopy, again, is the gold standard for making this diagnosis, but the findings on your scope fall back on your history and physical. You may see a TFCC tear, but that may not be what their problem is. And equivalently, you might see some scapholunate abnormalities, but if their history and physical don't point you towards a symptomatic scapholunate injury, then this is not necessarily relevant. So not only do you want to see if there's any fraying, but you also want to test how unstable it is. So whether your probe can get in, whether your probe can get in and turn, those are the Geisler classifications. Next thing I go on to after my diagnosis is physical exam. And my question is, how much range have they already lost? If they've already lost a significant amount of range, what am I hoping to achieve with a reconstruction? Perhaps I'm better off just going straight to a salvage, because in my mind, the downside of the salvage is that you're losing range. But if they've already lost range, I don't think that they will regain range after this procedure. These are the questions that were outlined by Dr. Garcia Elias, and I think this is a very good framework by which to assess and decide your treatment for patients with scapholunate injuries. And if you answer yes or no to these questions, it'll help guide you through what to do or what not to do. So we're going to start at the bottom. So the first question is whether or not the cartilage is normal. So if the cartilage is not normal, then don't even consider a reconstruction, move straight to some type of a salvage. If your degeneration is isolated just to the styloid tip, then you can consider doing a styloidectomy and a reconstruction. But if they have more extensive changes in the entire scaphoid fossa, and particularly in the midcarpal joint, then you need to think of a salvage procedure. The next question, I think, is the most challenging. Is the carpal malalignment easily reduced? So if you have a patient with a static scapholunate gap and a static DZ on your x-rays, it's very difficult to know preoperatively whether or not that will be reducible. We have different ways of quantifying that. Some people say, well, if you put a K-wire in and you try to correct the scapholunate angle and the K-wire is bending, well, that's too much force. But that, I think, is a bit arbitrary, right? Do you do a release first and then see if the K-wire is bending? How strong of a K-wire do you have in there? So I think it really becomes a gestalt that you get after experience. But I think it's important to have that discussion with patients. If you see a static DZ preoperatively, that you tell them, look, it may not be reducible, in which case, what do you want me to do intra-op? Do you want me to try anyhow? Or are you interested in a salvage because we think it may be more predictable? So it's important to have that discussion with patients preoperatively so that they know what kind of expectations to have. The next is whether that can actually be repaired. So if it can be repaired, definitely go ahead and do that. But if it can't be repaired, that's when you think about some kind of a reconstruction. So the repair can be open or arthroscopic. There are many different case series that show success. And if you do repair it, it's thought to prevent that late stage arthritis. If you open up a wrist with a scapholunate injury, this is what you will see, a big gap between the scaphoid and the lunate and the dorsally subluxated proximal pole. Now, if it can't be repaired, but it is reducible and there's no degeneration, then that's when you move on to reconstruction. And if it's reducible. So now, once you have all those, and think about what the patient, does the patient understand that this is going to be a lengthy recovery? They need to be immobilized for a significant length of time. They may need secondary surgery, in that we think that these reconstructions eliminate the risk of slack arthritis, but we don't know that for certain. That's what we think. But I think I always certainly do explain to patients that our goal is to prevent arthritis from developing, but I can't guarantee that. It's very likely down the road you may need something more. So I still think that we don't know the longevity of these procedures. And then when you're moving on to a salvage, I think that the concern there is whatever you're doing, it can't be undone. The patients need to sacrifice something. So they're either going to sacrifice range or strength. If they're moving on to something like a total wrist replacement, then obviously they're limiting their activity levels on a long-term basis. And I do consider these to be somewhat of a last resort. So here's a case example of a woman I saw. This is a 45-year-old nurse, and she had a fall. I would say like 7 or 8 months before I saw her. So a bit longer than we would expect to be able to have a successful repair. But she had a static DZ. She was not interested in a salvage procedure. So we attempted a scapholunate reconstruction. And I do like this 3LT technique that's described using the FCR tendon graft. I find this is reproducible in my hands and doesn't give patients too much stiffness postoperatively. So with that distally based slip of FCR, you're passing it through the scaphoid, tacking it down to the lunate, and then wrapping around those ulnar carpal ligaments back onto itself. She's done very well, a year post-op, and really fairly good range, 65 flexion and 70 extension, and equivalent strength. And it's interesting, I saw her recently for the other side, and she's still held up pretty well with this repair now, probably about 5 or 6 years later. This is a case who was interesting because he was a fairly high-level hockey player playing on a professional league, and he had symptomatic scapholunate injury. He was somebody that I would say was not reducible. This bent K-wire is his case trying to correct that scaphoid. Now, this was something that we discussed ahead of time, and he did not want to have a salvage. So going into it, we explained that if this is not reducible, we will try to reduce it, because certainly we all know that in surgery, if we really want to force a bone into a position, we can do that. But I think the likelihood of having that gap reappear is much higher. But we went ahead and pushed the envelope a little bit and did do his reconstruction, that same 3LT technique. And he's actually done well. I did not follow him beyond 6 months because he moved away. But he had persistent correction. X-rays looked good, and clinically, he was able to return to high-level sport without any issue. Now, this is another example of somebody that we had tried a reconstruction for an irreducible scapholunate, and he was in the same boat where he did not want to have a salvage. But I think that we did a little bit, our release and our attempt was a bit too aggressive, because when I ultimately saw him, he ended up with AVN of his scaphoid. So that scaphoid collapsed, unfortunately, and he ended up with a 4-corner fusion. A successful 4-corner fusion, but nonetheless, the scaphoid reconstruction, I think we pushed the envelope a bit too far, so it doesn't always work out. So why did these cases do well? And Andrea alluded to this previously, and I think that it was because that dorsal scaphoid subluxation was corrected. They will diastase over time. Explain to your patients that if you get another wrist x-ray, that scaphoid and that lunate will gap again. I'm not worried about that. I almost expect that. But the scaphoid fossa is quite broad. It can handle the scaphoid sliding radially. What it can't handle is the scaphoid sliding dorsally. So that is really your goal with this operation. This is a patient that had dynamic scapholunate instability. And these patients, you feel a little better about going in for the reconstruction because you know that they will be reducible. It's only when they're stressed does that scaphoid fall apart, or diastase, pardon me. And I've switched sometimes to trying this ECRL, and that's based on Dr. Garcia-Elias's feeling of these scapholunate friendly muscles and scapholunate agonists, so agonists and antagonists, pardon me. So the idea here is to take that dorsally based graft, the ECRL, and loop it around the distal pole of the scaphoid with the thought that they get a bit better correction. And I have to say this technique worked out fine. I have no issues with it. And this patient also did well. I felt maybe got a little bit stiffer, but it's hard to tell just on an anecdotal case. Now here's a patient here with, again, a scapholunate issue, but they have actually gone on to develop their arthritic changes. So this is when we're thinking more along the lines of a salvage procedure. So when would you do a 4-corner versus a PRC? I think in the American press, certainly a PRC has been the trend towards being favored, and the four corner getting a bit of a bad rap because of associated complications. But the four corner is my preference. I think this is great for younger patients that have heavier demand. Often my patients will already have midcarpal arthritis, so the PRC is actually not an indication is not an option for them any longer. And I think with a PRC, the capitate was not meant to articulate with the radius. So the longevity of that procedure is certainly in question, particularly for younger patients. So I think that four corner fusion, if you pay attention and do a very meticulous surgical technique, the complications can be managed well. But for older patients that may have a higher risk of non-union, whether they're smokers or diabetics, or you just think compliance is going to be an issue, I use the PRC. Or if patients prioritize maintenance of their range over grip strength and longevity of the procedure. There was a systematic review looking at PRC versus four corner fusions. And as I alluded to previously, four corner fusions do have a higher complication rate, and it's mainly related to the hardware or non-union. And that's often why the postoperative range of motion arc is not overly different, 62 degrees versus 75, and grip strength was favored slightly towards the four corner fusion at 74% versus 67 of the contralateral side. We did a little study at our center, which is hopefully going to be published soon, wondering, does the method of fixation matter for these four corner fusions? So this is basically my series of in my career. I started off early on using staples because that was what was sort of the standard. And then I shifted over to using headless compression screws. And I think the headless compression screw technique really actually works quite well. So you can see the pre-op flexion arc versus the post-op flexion arc for the headless compression screw really was not very different. They lost some range, but certainly not half their range, and certainly an insignificant drop. Versus the patients that had more of a dorsally based fixation technique, like the staples, they lost a significant arc of range between pre-op and post-op. In fact, if you looked at their pre-op arc of motion and their post-op arc of motion as a percentage of how much range they had, nobody lost 50% of their pre-existing motion, and some of the patients in the headless compression screw actually gained motion. Grip strength was actually improved following a headless compression screw fixation, although that was not significant, while the staple group had a loss of grip strength. Our fusion rates and the mean time to fusion were much better with the headless compression screws, a shorter length of time in the cast, a higher percentage union, and a shorter length of time to achieve union. Some of the limitations of this preliminary study are that there was no comparative group, so we don't know if these patients would have done better with a PRC. A small sample size in the general statistical sense, but I think from the literature on four corners, it's fairly reasonable at 64. And we did not have pre-operative outcomes for these patients, only post-op. So some tips I would say for compression screw, if you're thinking about using compression screws for the four corner, really shorten your screw length significantly from what you measure. You've got the cartilage on either side. You certainly don't want to leave your screw prominent proximally. And you also get a significant amount of compression at the fusion site, so account for that. I always put the bone graft in first before I implant the screw, and that's just because these screws generate so much compression that you almost can't get any bone graft in. And you don't need to connect all four bones. Just connecting those two columns seems to be enough. If I can, I like to have a fairly ulnar start point for my screw. I think this cartilage is what's articulating with the radius. You want to preserve that if at all possible, but that's just my sort of anecdotal report. I don't have any evidence to back that up, but I think it makes sense to try to keep that whole, that screw entry point as far ulnar as possible. Correct the DZ, make sure that you restore that lunocapitate angle. So in summary, if you're thinking about saving these scapholunates, history and physical are important. Assess the status of the cartilage. Determine whether or not that scapholunate is reducible or irreducible, and make sure that what you can offer aligns with the patient's expectations. Thank you.
So I'm honored to speak about Ruby. I have worked with her very closely for a number of years. She's the most dynamic surgeon. I worked at the Hand and Upper Limb Center. We worked very closely. We had a bit of a discussion, academic discussion off and on. And I'm quite happy to say that, Ruby, I thoroughly enjoyed working with you. I miss being with you, especially in the clinic, and then spending some time discussing about certain cases. So everyone heard you speak. You have given a marvelous presentation about talking about different procedures you prefer for different categories of these patients. And I'm sure all these patients are happier or living happily after your surgery. And you have done a remarkable job. So thank you very much for talking about the repair or despair. And I think there is room for repair or despair in different situations. So thank you for presenting this beautifully. So with this, I think I'm going to pass it on to Dr. Jerome, who can then bring in Dr. Abhijeet Wahegaonkar to speak or present his topic. Thank you very much.
Thank you, Shrikant, and thank you, Dr. Ruby. It was an excellent talk. And I say it's completely mesmerizing about, to delineate, save or salvage. Absolutely, it's fantastic. We'll have a lot of questions for you. So we have Abhijeet here who's joining with us. Abhijeet, welcome. Abhijeet, we can't hear you, Abhijeet. Sorry. We can't hear you, Abhijeet.
Abhijeet, I think you have to unmute yourself, please.
Sorry, we can't hear you, Abhijeet. You want to log out and log in back, Abhijeet? Yes, sure. Yeah. In that case, probably we can have questions to Dr. Ruby and to Dr. Andrea about the talk. So that probably when Abhijeet joins back, we can have his talk. A couple of questions to both of you. We have actually read the article from European Journal of Hand Surgery about the author Blackburn has given an article about the role of surgery for scapholunate injuries comparison to the just simple neurectomy, the posterior intraosseous nerve neurectomy. How do you feel that, which really contributes much in case of your outcome? We know that this paper has a lot of worries and controversies. Going and repairing or reconstructing scapholunate injuries versus just do a neurectomy and cauterize the posterior intraosseous nerve. People are happy. What's your take on that? Both of you can.
For myself, I think if the patient is young and active, and has like Ruby outlined, no arthritis and a reducible scapholunate, I will go ahead and offer them that. But I will take the PIN out every time. Now, I did not used to, because I thought that it's perhaps plays a role in neuromuscular control. However, I've gone back in, or have had cases that have been sent to me of people have wrist pain, and I've seen a neuroma in that area because we're operating right there. And so I actually take out the PIN routinely now to avoid introducing another reason for pain. But for, for the patients who are maybe a little bit older and are not quite happy with the longevity of the recovery time, then that might be that is a step that I do offer them, but I'll do PIN and AIN as a partial wrist denervation.
I agree with what Andrea is saying, and if I'm doing a salvage, I definitely will take out the PIN. Offering a neurectomy on its own, I have to admit I don't do often, almost ever. I find they usually have some sort of structural issue, and while the neurectomy alone will certainly help their symptoms, I don't think it gives as reproducible pain relief or improvement of function. However, if you have somebody that's not able to handle the demands of the recovery or the rehab, then it's a great option. But I find for those types of patients, you can usually just keep treating them conservatively with splinting, cortisone injections and stuff like that, and sort of anesthetize that nerve with repeat, sort of staged injections as well. So I don't often do an isolated neurectomy if I think there's something structural I can fix.
Thanks. Both of you, thanks. The other question is, very rarely we come across the scapholunate injuries in children. I have seen one scapholunate injuries in children. How do you manage?
Yes, I've seen one in a child actually recently, and I actually, when I went into the wrist, was concerned for an underlying inflammatory condition when I went in there. So I went in with a scope first to take a look, and there was so much synovitis that was unexpected, and so I reconstructed it with just purely soft tissue reconstruction. And then I sent him to rheumatologist. So I think it's very rare. I think if they're going to do anything, they're going to break their scaphoid, not disrupt the ligament. And so, I mean, I have very limited experience with this, but the one that I did see, there was a lot of inflammation, more so than any other patient I had seen. So I feel like there might be an underlying condition to look for. So keep that in mind.
I don't think I've ever seen one. I think they are extremely rare. Now, pediatrics is not a huge part of my practice, but I think one thing to keep in mind is if you go through the ossification pattern of the wrist, as the scaphoid and the lunate are maturing, there's a lot of cartilage in that space. So when you have a very young person and you look at their wrist, it looks like there's a big scapholunate diastasis, but it's just because of their bone age and the pattern of ossification. So if you're uncertain, X-ray the other side, you'll get an idea of what their normal anatomy is, and don't be fooled into thinking there's a scapholunate gap when in fact it's just because of their skeletal immaturity.
Absolutely reiterate that. I think there's a good study by Donald Bay and Peter Waters looking at scaphoid fractures, actually characterizing that in kids. And so originally it was thought that these fractures are occurring more distally than thought, but because of the ossification centers, actually it's very similar to adults, wherein the majority of these are occurring in the waist because of the highly cartilaginous proximal pole. So yes, always get the other side in kids. Don't assume that it's scapholunate injury. Very, very rare.
Yep. Thank you. We have Abhijeet probably is ready with the presentation.
Yeah. Can you hear me now?
Perfect.
Alrighty. I'm terribly sorry for this glitch. I don't know. These computers always have some problems. So thank you so much for the opportunity. And I would like to thank Dr. Shrikant and Terence. You've been doing a great job with continuing academics in this difficult situation when we have this terrible COVID thing going on. And I think Andrea and Ruby have just made my job so much easier to, talk on scapholunate ligament injuries. I'm just trying to find my presentation and should be up in a moment. So my task would be to talk about a general strategy or an overview of dealing with scapholunate ligament injuries. And is my screen visible now?
It's opening. PowerPoint is opening.
Yeah. Is it okay now?
Just give us a second. Yeah, perfect.
All right. So I'll be talking about strategies for the treatment of chronic scapholunate injuries, and um, I don't have any disclosures regarding this talk. So let us begin with a case presentation. This is a 42-year-old right-hand dominant male who presented with pain in the right wrist joint with a history of a fall on an outstretched hand. And this injury was about 6 months prior to presenting to our clinic. And when he presented to our clinic, we found that he had significant pain related to activity, and there was snapping sensation in his history. And I want to thank Ruby to really highlight this very important aspect of dealing with scapholunate injuries. There is really no substitute for a thorough clinical examination and a good history elicitation. And I think that itself is a paramount parameter in diagnosing these injuries rather than relying solely on your investigations. So clinically, he did have restriction of joint movements with point tenderness over the scapholunate region and in the anatomical snuff box with a positive scaphoid shift test, and the x-rays revealed this particular pattern. And we have already seen this in the previous talk, so I won't belabor too much on this. Suffice it to say that the scapholunate angle was altered. And obviously, at this point in time, what would you like to do? Would you investigate further? Would you splint? Would you subject this patient to rehab, or you would want to wait and watch? And I'm sure that almost everybody, after the backdrop of the previous two talks, would want to investigate further and find out whether this gentleman would merit some kind of an intervention. So we went ahead with these investigations, and as everyone would agree, this is a scapholunate injury. Now, we will come to how to deal with this, or the decision-making process and the options for dealing with these injuries in a bit. But before that, the diagnosis of scapholunate injury, especially the chronic scapholunate injury, you do have to consider the grade. So depending upon the ligament classification or the more recent classification proposed by the EVAS by Dr. Jane Messina, you need to take into consideration the patient requirements, the surgeon preferences or training, and the options that are available at your institution or at your practice location. So we all agree that scapholunate dissociation is an extremely common pattern of carpal instability. It is a dissociative kind of instability. It has a known predisposition for development of arthritic changes, and we have to recognize that understanding the anatomy and mechanics is a prerequisite for appropriate treatment and be able to deliver optimum outcomes. So pretty much the treatment of these injuries depends on the classification. And there are several classifications in literature, and they are based on the durations such as acute, subacute, or chronic. And of course, then you have the slack wrist. Depending upon the severity or the grade, you would classify them as static, dynamic, or pre-dynamic. And again, this would help you in determining what the best treatment option for your patient would be. And again, there are classifications based on the etiology, such as a ligament disruption due to trauma, inflammatory arthropathy, congenital iatrogenic, and infections. So all of these are going to have an impact on your decision-making process as to what the most optimum treatment for your patient would be. And then, of course, we all do recognize that scapholunate injury would also be associated with more complex injuries, such as perilunate patterns, or you would have these complex trans-scaphoid perilunate dislocations, for that matter, or greater or lesser arc injuries. And again, you would have to factor in these complex instability patterns and then deal with these patients in a more effective manner. You also have to consider situations where the carpal instability is secondary to a pattern such as the carpal instability adaptive, or an adaptation to an extracarpal or an intracarpal pathology. And again, this would impact your decision making. So I cannot emphasize this enough, that the treatment depends on the classification and the surgeon's preference. Also, we need to, kind of keep in mind that Richard Berger made this very solemn statement, where he said that treatment of scapholunate dissociation is difficult, not always predictable, and seldom entirely satisfactory. So there are certain classifications that have been elaborated by Mark Garcia Elias and Dr. Wolf, as was discussed in the previous talks. And we do consider these factors, and they help us again in decision making and in coming up with an appropriate treatment strategy. So in this particular slide, you would see that we have this very nice and a very good table. And I really encourage everyone to keep a printout of this table and those questions handy in your clinic, because they just help you and your residents make very appropriate treatment decisions for your patient. So depending upon the stage and depending upon the fact if the scapholunate ligament is intact, what are the chances of healing, looking at the instability patterns, and then of course about the reducibility of the pattern of the instability pattern, you would then come up to the treatment option. So the natural history of this disease is, or of this dissociation, is that it will progress to degenerative disease, and the treatment principle in a bird's eye kind of a view, in acute injuries you would repair or you pin, in chronic you would reconstruct, and there's a litany of open and arthroscopic techniques, and we very quickly and briefly review them. When there are arthritic changes, you would opt for a salvage procedure, and then when there is very severe or mild pain associated with this, you would also deal with them with salvage procedures. In inflammatory or infectious problems leading to scapholunate association, you would resort to a salvage procedure, more often than not an arthrodesis, whereas reparative or reconstructive procedures are more appropriate for the carpal instability dissociative. And then, of course, there are other procedures that we'll just discuss in a little while. So the treatment recommendations are again also elaborated depending upon where the injury pattern is, whether it is volar, dorsal, or an intraosseous aspect. And we all recognize now that the dorsal aspect of the scapholunate ligament is the most important or the strongest. However, with arthroscopy and these biomechanical studies being elaborated further, we also now factor in the volar aspect of the scapholunate ligament, and thereby we now have this box concept of reconstructing the scapholunate ligament. The options for open treatment are ligament repair and augmentation, such as that using an internal brace, performing a capsule adhesis procedure, a bone, ligament bone or a bone tendon bone kind of a construct, and of course ligament reconstruction, which could be done either open or arthroscopic, as has been demonstrated by our very astute colleagues such as P.C. Ho and Professor Mathula and Andrea and others. So how does this classification help in decision making? So this again has been described in the previous talk by Ruby, but suffice it to say, up to stage 4, this is a dynamic instability pattern, which means that the scaphoid is still reducible. Stage 4 and 5 are more or less static. And then, of course, you're degenerative as it comes to the stage 6. So up to stage 4, when there's a complete scapholunate ligament injury that is non-repairable with an easily reducible subluxation or a flexion of the scaphoid, and the cartilage is normal, we would then use ligament reconstruction using these tendon grafts. And there are several ways to do it, and we'll just come to that in a bit. However, stage 5 and stage 6, when the ligament is non-repairable with an irreducible rotatory subluxation of the scaphoid and the cartilage is normal, you could still try this, but if the cartilage is damaged, you would go on to a salvage procedure. So these are wonderful schematic diagrams from Martin Langer. And you could see that the techniques have evolved right since the time of Linscheid at the Mayo Clinic, where they have described using these tendon weaves. You have the Blatt's procedure, where there's a capsular advancement, the Armkus procedure. So there is a litany of these very intricate tendon weaves. And the idea of any of these procedures, be it capsulodesis or a tenodesis or a tendon weave, is just that we need to correct the rotatory subluxation of the scaphoid and bring it back from flexion to extension and maintain it that way. A lot of times you find with these procedures, the diastasis is not addressed very effectively. However, the scaphoid flexion can be corrected, and thereby we try to restore the kinematics and the kinetics of the scapholunate articulation or that of the proximal carpal tunnel. So again, I won't belabor too much on these techniques. They're all out there in the literature for you to read. And as recent as 2015, I guess, when Andrew Chen and Mark Garcia Elias, they described the spiral tenodesis. We have multiple techniques as was seen in the previous slides. We also have advances in the availability of the internal brace, and they have also been modified as described by Sanj Kacker and Dr. Ale from Germany. And what they also do is they try to reconstruct the volar aspect of the scapholunate ligament, thereby trying to improve the stability of the articulation. What are the outcomes of all of these procedures? And I should, share the study by my friend Kai Megel from Germany. And it is very humbling to look back at long-term results. We might think that we've done a great job and the immediate or the early or the midterm outcomes may look pretty good, but the long-term outcomes systematically need to be reviewed. And what he showed was that dorsal intercarpal ligament capsulodesis for the treatment of scapholunate ligament instability almost always results in a systematic loss of arc of motion, and the kinematics and kinetics are not fully restored because the kinetics and kinematics are just not flexion extension and radial and under deviation, but there's also a little bit of torque that is associated, and that's almost impossible to restore. So there is always a dilemma, and we question as to what is the best way to deal with this entity, wherein we can still maintain the maximum possible arc of movement and preserve near normal kinematics that can last a very long term. So this is an evolving question which has led to several investigators trying to come up with techniques which are minimally invasive, thereby trying to maintain the anatomy and the biology of the or the environment of the scapholunate ligament. And we drew our idea from this study that was published long ago by El Saidi. And pretty much like the studies of Dr. Wolf and what Terence mentioned, a sequential sectioning of the scapholunate ligament and the extrinsic stabilizers does lead to a systematic increase in the gap or the diastasis, and ultimately when you section the dorsal aspect of the stabilizers onto the scapholunate ligament, that is when you start seeing the DC pattern. So we did these studies and we did a sequential sectioning of these ligaments arthroscopically in lieu of the previous studies that were done in an open manner. And we found that there is a worsening or an increased diastasis of the scapholunate. And when you detach this entity, which we called as a dorsal capsular ligament septum, we found that the DC pattern starts appearing. So the DCSS is essentially a reflection of the dorsal capsule or condensation of the capsule onto the scapholunate ligament, which kind of stabilizes this articulation of the dorsal capsule. And this entity led us to think of an arthroscopic technique, which was a brainchild of my mentor, Dr. Professor Mathula, which is a very neat technique. And I want to thank Martin Kaloya and Professor Mathula for sharing this video. And what we do is arthroscopically, we identify the scapholunate ligament injury, and then we look at the remnants on both the scaphoid and the lunate. We go to the mid-carpal joint and you retrieve these sutures that have been passed through these remnants, and then you tie a Nicky knot, and then you pull on the limbs that are outside the skin, and thereby you accomplish a capsuloligament kind of a decis technique. You bring everything together, thereby stabilizing. There have been also modifications in this technique wherein even if the remnant were not to be found in the scapholunate ligament, you could still do this procedure by the use of anchors and the newer modalities of treatment that are available. So Max Herrle has been instrumental in modifying this technique and making it a more robust procedure. So here you can see the clinical picture wherein I'm trying to grab the lunate or the scaphoid remnant along with this needle being passed through the capsule. We retrieve the thread just like so. Another pass is made, and then as you pull on the limbs, the knot will come and sit inside the joint, and as you tie the knot, the scapholunate articulation comes together. We have published our outcomes in several different studies, and this was the first one that we published where we looked at 57 patients. This was a retrospective study, and we found that we had a very good improvement in the Mayo risk score and the VAS score, and most of these patients returned back to the previous level of activities, including sports. We did have a couple of complications in terms of reflex sympathetic dystrophy and some stiffness that was resolved. So these initial studies and their outcomes were pretty encouraging, and as we speak, we are in the process of undertaking a multi-center prospective study, and once we have these results, they will only be helpful in validating the study as being a reliable and a reproducible procedure. So in summary, the Mark-Garcia classification is an extremely important tool in helping us to make the decision to deal with this in a very appropriate and an effective manner. This slide gives a pictorial kind of a view as to how we could deal with different stages with different techniques. And this has already been discussed. Obviously, stage 4 and 5 and 3 are where the scaphoid is reducible, and you would do either a ligament reconstruction using a tendon graft, or you could use an internal brace to deal with these injuries. Stage 6, where you may use the Rassel procedure, an arthrodesis or a partial wrist fusion, and stage 7, of course, is where you would require an arthrodesis, either partial or a full wrist fusion. So you really need not despair when you find these injuries. I think Dr. Berger made the observation, our understanding was still evolving, arthroscopy was still evolving, the instruments and the techniques were evolving, but now I think we are seeing a paradigm change in the management of scapholunate injuries. And we can certainly repair, reconstruct, or salvage. We need to optimize our outcomes by advancing skills and knowledge. And of course, we need to have proper patient selection, counseling, and have the proper indication to have the best possible outcomes. So with that, I thank you for your attention. Any questions? I'll be more than happy to take. Thank you.
Thanks, Abhijeet. I used to say, Abhijeet, you look like my brother, but I say to another mother. It's been fantastic, and thanks for joining us.
Thank you.
Besides your busy schedule, we have been occupied somewhere also today, and thanks for joining us and enlightening on this webinar.
Thank
We
you.
have a couple of questions, and then probably we'll end the session. Quick questions on terms of rehabilitation in patients whom you repair the ligament or you reconstruct.
I beg your pardon, and I get that.
The timelines of rehabilitation in patients whom you do a scapholunate repair and you reconstruct, for example, 3LT.
Right. Well, it's pretty much the same. We like to immobilize for about 6 weeks, 6 to 8 weeks, in fact, if I'm repairing, with no hurry to kind of start range of motion. In case you're done at ligament reconstruction, maybe we can think of rehabilitating anywhere between 4 to 6 weeks. Um, we start with gentle range of motion exercises, then we bring in the patient for the dart throwing motion. We put them on some, uh, proprioceptive exercises and then strengthening exercises. I'm sure Dr. Chinchalkar would like to add his wisdom to this particular aspect of rehab.
I mean, in the literature, there's quite a bit of controversy as to how these patients are mobilized or immobilized. I mean, looking at, say, for example, acute repair, yes, you may have to consider that you don't want acute repair to fail. So in that situation, definitely, you may have to consider some immobilization. However, some short arc of motion may be permissible, which can be identified fluoroscopically once you have done the repair or acute repair of these ligaments. Because you'll be able to identify the relationship between the scaphoid and lunate as you're moving your wrist, going into dart throws motion, for example, going into extension and radial deviation by maybe 10 degrees or 15 degrees, going into flexion by 10 to 15 degrees. So you have that intraoperative information already available that we can pass on to the therapist. Then recommend that dart throws motion in this particular and progress not immediately, but maybe progress by increasing 10 degree of motion, flexion and extension every 2 week period of time. We know that following immobilization, the consequences of immobilization include stiffness, and of course, if your ligamentous structures, whether they are repaired or whether they are reconstructed, they are bound to be tight. And we know that once the structures are tight, when you attempt motion, then there's a greater joint compressive force because these structures will not have any translation of motion, so to speak. And as you are moving your muscles, it is going to draw your radiocarpal and metacarpal joints significantly in the compressive state. And as the patients are trying to bend at certain point, then there is a great amount of bending force placed on the repair structure, which are likely to fail over time. There are some studies which have shown that the motion is a critical factor in increasing the DNA content as well as the water content of the ligamentous structure. So why not go with the short arc, starting off with maybe limited motion in extension and flexion after scapholunate ligament repair or reconstruction, and then gradually progress on an ongoing basis. And most of the time, these patients are often seen by the surgeon uh, for follow-up. Maybe these patients are brought in after 10 days for suture removal, and then at that time we check the microscopically and then make a recommendation as to how much rotation we need to include over time. So this is my take on what I can, because if they are stiffer, then they're more stiffer they are, the more painful they're going to be. More stiffer they are, then there's going to be a greater amount of compressive cartilage. So the bending force placed on the ligamentous structures are likely to fail as a result of patients attempting to move at a later stage. And even though you may have considered giving these patients grass, for example, or any dynamic or static progressive splinting, it is going to do the same because the structures are not pliable enough in allowing some motion. And on the contrary, you're producing greater bending force and greater translative forces at the radiocarpal. This is my opinion, but of course, you see these patients more frequently and have experience with this. But immobilization, I mean, if you look at the wrist joint, it is either overly treated by immobilization or not adequately treated by means of other methods.
Thanks, Dr. Shrikant.
Thank you.
A couple of questions, but then due to time, probably we'll have only one questions for all the panelists. We all know that the scapholunate ligament, the dorsal aspect, is the crucial structure to repair, or even the dorsal capsule reconstructive surgery. When I was traveling a fellow to Mayo, I found very interesting surgery. They could take that LRL, long radio lunate ligament, and then they could reconstruct putting anchors to the lunate and tightening. Once they do the tightening, it's so magic that the diastasis gets reduced. What's the thought on that? Are we changing the paradigm from dorsal to olar?
The paradigm's changing to not switching, but addressing both. I think in unpublished data from our group at the Hall, we demonstrated that there's differential gapping in our cadaveric in vitro study once that there's full sectioning of the scapholunate ligament. And when you go from wrist neutral into wrist wrist flexion, you see differential gapping with more gapping dorsally. And so I think with the greater understanding of the importance of both dorsal and volar, and the introduction of techniques that are addressing both the volar and dorsal, I think the paradigm shift is to try and design techniques that are anatomic, rather than focusing only on the volar or only on the dorsal. But I mean, that's my take. Yeah.
Agree with Andrea. I think that we always sort of historically thought the volar component was not important, but I think it's showing more and more in our biomechanical research that it does play a significant role.
Yeah, I agree. I think more and more people are recognizing the importance of the volar aspect of the scapholunate ligament, and I think an arthroscopy for these patients can really put it into evidence, and that can help you in making good decisions about whether you should address the volar aspect or not. It's a quick kind of a procedure where you can scope and probe and find out if the volar aspect also is unstable, and then deal with it accordingly. Whether you repair it, whether you need to reconstruct it, it could all be done. So.
Thanks, Abhijeet. We are probably winding the session. Before that, a quick 30 seconds from all the panelists, and probably we'll wind up.
I'm just looking at the chat box. There is a question. I'm not sure how to actually post the answer, but there, just to share with everyone. So there's just a question about the K-wires, about whether we leave them under the skin or prominent. And I leave them buried under the skin for about 8 weeks. I like what Shrikant's saying about starting some early range. Sometimes I will pull that mid-carpal pin out at 6 weeks to start a short arc motion, but I like to keep them otherwise immobilized.
Thanks. Dr. Andrea, Ruby, and Dr. Shrikant, Abhijeet, a quick 30 seconds closing remark.
Andrea, you go first.
I go first. Yeah, no, I'd just like to thank Terrence for inviting us and Shrikant for hosting to provide this opportunity. I think for myself, we're still searching for the optimal scapholunate reconstruction to address all these points. And I think really I'm in the camp of dorsal scaphoid translation is the top priority to reconstruct and maintain beyond the diaphyseis, beyond even the DZ, because I think that is really what proves to be symptomatic for patients.
And I would say just focus on history and physical. That's going to be the key. Don't get tied up on what the imaging shows. Treat the patient and the clinical problem that they're presenting.
I think I would corroborate all that you two have told in your fantastic talks. And what I would like to say is that we really need to be very critical about our own outcomes. We need to look at our outcomes and especially our failures, and we need to have a very critical evaluation as to what went wrong and keep on improvising, keep on improving. We need to be very open to newer ideas and not be dogmatic, because I think as we grow old, we just become so complacent with what we think is the best way to deal with things. And every time I listen to you guys speak, there is so much I learn. There is nuances that really help me in improving the outcomes for my patient, because I think we need to understand whatever it is that we do has a direct repercussion on the lives of our patients. So thank you so much for all the teachings. I really appreciate it. Thank you.
Thank you, Terrence, for inviting me to organize this session. And I'm honored to have presented Andrea, Ruby, as well as Abhijeet. Thank you, three of you, for agreeing to participate with me, because you guys do a great and marvelous job, not only treating these patients, but also presenting your material to a degree that everybody understands and takes some insightful messages. Thank you very much, three of you, for agreeing, and then Terrence, thank you for including me in this session.
Stay safe, everybody. Thank you so much.
Thank you so much. Thank you for your time here. Delegates, participants, that's all here for today. The carry-home message is very simple. Dr. Andrea said the dorsal scaphoid translation is more important. Think about it. Dr. Ruby emphasized on clinical and history is very important. Abhijeet, thanks. You made open to all surgical techniques and critical analysis of outcomes. Shrikant, amazing moderator. Thank you all. Thank you. We are reeling under this COVID, and hope we will get back safely and healthy. Thank you once again for all your active participations. Thank you. We'll meet up soon. Thank you very much.
Thank you. Stay safe,
Bye.
everyone.
Thank you. Bye. Bye.
Shrikant, I'll call you back.